All right, Barbara Garcia back here with chapter 25, acid-base homeostasis and imbalances. This is actually a really important chapter. It's going to be a little bit shorter than chapter 24 was, so hopefully less than an hour is my goal. All right, so understanding the normal mechanisms of acid-base homeostasis is very important to understanding, right, acid-base imbalances. So remember, go back, way back to your physiology class. You remember the bicarbonate buffering system, okay? So the carbonic acid buffering system. And so that you want to make sure you know backwards and forwards. And this entire chapter surrounds that, basically that one equation, okay? So make sure you know, right? So pH of a fluid, right, it's going to reflect the degree of acidity or alkalinity. So if you have your acid-base balance, carbonic acid buffering system in your mind, remember that at the right side of this equation, you have hydrogen ion and bicarbonate, right? On the left side, you have carbon dioxide and water. In the middle, you have carbonic acid, right? So if you look back on the right side, pH is measured by the concentration of hydrogen ion in the blood, right? So remember, the carbonic acid buffering system works in the blood. It maintains our blood pH between that very narrow 7.35, 7.45, right around 7.40. Okay, so 7.40. So it's very important that we do that. So pH is actually going to be gauged by whether or not we have a high concentration or low concentration of hydrogen ion, and it's related to that hydrogen ion comes from this equation. For the most part, I mean, there's other things in our body that make acids, like if you have lactic acids being made, but the majority of the time, this is going to reflect that. And that's what we're going to use to compensate for those shifts. Okay, so your pH is going to be almost directly related with the ability of our carbonic acid buffering system to maintain our pH. Okay, so cellular function will become impaired when obviously pH of body fluids becomes abnormal. So when we look at acid-base imbalances, we're talking about metabolic acidosis or respiratory acidosis. So which one is coming from which source, right? At metabolic acidosis means that something in your body, your tissue or cell is making extra acid, right? Or something that you're consuming might be extra acidic. Whereas in respiratory acidosis, because the left side of that equation has carbon dioxide involved in it, then definitely is going to be related to your ability to excrete carbon dioxide. So I want you to think of the two main organ systems that are functioning in acid-base homeostasis. That is our ability to breathe, right? So if we can get rid of the adequate amount of carbon dioxide, not too much and not too little, we're going to be good, and our acid-base buffering system is going to be, our carbonic acid buffering system is going to be fine. If it is over, right, over shifted, then you're going to have a respiratory acidosis. So for example, if you increase carbon dioxide in the blood, it's going to shift, right? Remember, these are reversible reactions. It's going to shift all the way to increase your hydrogen ion concentration. Remember, with a higher hydrogen ion concentration means that you become more and more acidic. So your pH goes lower, right? So now you have a respiratory acidosis. Now the other organ system that is going to significantly function here is the kidney, right? Your renal system and your ability for your kidneys to eliminate or, remember, excrete or secrete and excrete, or to filter, right, and reabsorb other ions, right, especially hydrogen ion and bicarbonate ion. So if we balance those, then those can also affect and shift this carbonic acid buffering system, right? So those are your two important ones. Usually the respiratory system works very quickly by adjusting the amount of carbon dioxide that you exhale, but it cannot make major shifts in pH, only minor shifts in pH. But your urinary system can do major shifts in pH, and can really save your life if you were to become, acidotic. However, the major problem with that one is that it's going to take 24 hours. So as long as your condition is not immediately fatal, then if it gets about 24 hours, the urinary system can adjust. So that was my little review there. All right, so pH, right? So 7.35, 7.45, a little wider in infants and children, right? A higher pH indicates that you have less hydrogen ions, right? And so in the case where you shift your bicarbonate, so I need you to make sure that you have somewhere written your carbonic acid buffering system. Okay, so you're looking at it because I'm going to talk a lot about it. So if you have very few hydrogen ions, right, you're going to, if the hydrogen ion concentration goes down, the ideal scenario is that you would right shift, right, so everything moves to the right to make more hydrogen ions. So that means that you decrease the amount of carbon dioxide, and so you're going to breathe less. Your respiratory rate would decrease in order to increase the amount of hydrogen ions and return your pH to normal so that you're no longer alkaline or basic. A low pH indicates a lot of hydrogen ions. So if you had a lot of hydrogen ions, right, which means that the right side, right, of your equation is very high, right, because that's where the hydrogen ion concentration, hydrogen ions are, and bicarbonate is. So then you would left shift. So if you had a lot of hydrogen ions in your blood, right, and you're very acidic, then you're going to left shift and you're going to make a lot of carbon dioxide. And if you can eliminate that carbon dioxide, then you're going to balance out. If you can't, then you're going to have a problem. All right, so pH, if your blood, right, become too acidic or too alkaline, right, a dysfunction can occur in any one of your organs, and even death, right? So death is going to occur if your pH falls below 6.9 and your pH rises above 7.8. So you really want to stay within 7.35 and 7.45. Outside of that, it could be detrimental. All right, so again, this is a normal, right? So maintenance of acid-base balance reflects homeostatic functions of normal cellular metabolism. Remember that your ability to maintain homeostasis means that all of your cells are functioning normally, right? So if there's something that is not functioning normally, then one of the things that could be affected is your acid-base balance. All right, so normal laboratory values for your acid-base parameters. So pH, right, we already know that, 7.35, 7.45, right? Your partial pressure of carbon dioxide, okay, so that's really important. In adults, 36 to 44, okay, so around 40 is normal. In your arterial blood, your bicarbonate range is between 22 to 26 milliequivalents per liter, okay? A little different, a little bit wider for the infants, right? So we have buffers that are going to maintain and regulate acid-base status of our body. Again, the carbonic acid buffering system being the most important one that is found in the blood, right? In the blood. We have others that are more seen inside the cell, like the phosphate buffering system. And then again, this is respiratory and renal system, and basically that's one of their very important functions, right? So arterial blood gas, right, is going to measure, right, these useful indicators that let us know our acid-base balance, right? So a partial pressure of carbon dioxide indicates our respiratory function. So if we're breathing properly and we're eliminating the right amount of carbon dioxide, then that should be normal. right? Our bicarbonate, right? Renal metabolic function. If our kidneys aren't eliminating the right amount of bicarbonate, then we're going to have a dysfunction, right? And then obviously pH, which is going to be basically making sure that our body's compensatory mechanisms are all appropriate, but for the most part, remember, inside the blood. It does not really reflect the pH of the inside of the cell or the cerebrospinal fluid, right? So it is, however, the net result of normal acid-base regulation. So that's what our blood pH is going to indicate to us. All right, so buffers, right? So again, our carbonic acid buffering system being the number one of our buffers that's going to help defend against pH changes. I want you to notice that the arrows, right, are both ways, right? So this equation can go in either direction depending on which direction. Which of them do you have more of? Where there's more of one, that one becomes the reactant and the other end becomes the product. Okay, so I want you to think of it like that, right? It depends on the direction that we're going. When there is one that's higher concentration, that means that you're going to have it go in the opposite direction of that. Okay, so if your hydrogen ion concentration were elevated, right, you're going to go in the direction of carbon dioxide, which is to the left. Okay, again, pHs, okay, so buffers are anything that can do what that equation that I'm sure you have in front of you is doing, right? It takes the hydrogen ion and binds it to bicarbonate or unbinds it to bicarbonate. So basically, it's either making the hydrogen ion available to affect your pH or hiding it away from your system so that it's not available to affect your pH. That's a buffer. Anything that can do that is a buffer, okay? Some of our proteins can do that. So proteins often function as buffers, but they're inside the cell, not so much in the blood. Although it could affect the blood because there are some proteins in the blood, right? But that protein buffering system is going to be more seen inside the cell. Phosphate. So I don't know if you remember that you can have phosphate, which is PO4 2-, can also be monohydrogen phosphate, which is HPO4-, or it can also be dihydrogen phosphate, H2PO4. And depending on how many hydrogen ions it's going to pick up, depending on the pH inside the cell, it is going to pick up 1 or 2 hydrogen ions or deliver 1 or 2 hydrogen ions. So it is a very, very powerful buffer, but that's inside the cell, okay? Right, so chemicals that help control the pH of our body fluids, right? So this is what a buffer is, right? So weak acids that release hydrogen ions when a fluid is too alkaline, or a base that takes up a hydrogen when the fluid is too acidic, right? So bicarbonate buffers, phosphate buffers, hemoglobin buffers I didn't mention, but hemoglobin is a protein, so you know that it can do that just like a protein buffer works. All right, bicarbonate buffering system is our primary defense against acid-base disorders. The most important buffer in the extracellular fluid, mostly again found in the blood, but extracellularly, it's going to be important throughout all of our extracellular fluid, right? So bicarbonate ion is the base, the weak acid is carbonic acid, and it's maintained basically in chemical equilibrium in your extracellular fluid. So usually you have 20:1 ratio of bicarbonate ions to carbonic acid, which is necessary for a normal pH. Right, so too much acid, like for example, you make lactic acid, right? And you become acidic, right? So bicarbonate ions take up hydrogen ions released by the acid, like lactic acid, become carbonic acid, and then carbonic acid releases it as carbon dioxide through the lungs. Like I told you, now too much hydrogen ion causes you to left shift, right? So then in too little acid, right, when the H plus on the right side is too low, everything else is high in relation, yes? So the bicarbonate buffer then is going to release hydrogen ions from the weak acid, carbonic acid, and release it to increase your pH. Right? So your defense against acid based disorders is your respiration, right? So obviously our ability to excrete carbon dioxide and water from the body is our ability to essentially get rid of carbonic acid from our body, right? So if the hydrogen ion binds to carbonic acid, and then the carbonic acid is made into carbon dioxide and we excrete it out of the body, then we have eliminated essentially and returned a pH that was too high, too much hydrogen ions, back to something normal, right? So changes in rate and depth of respiration can actually, right, result, right, from stimulation of chemoreceptors that detect your carbonic acid partial pressure and the pH of our blood, right? And so then they can influence and serve to alter that carbonic acid partial pressure and partial pressure of carbon dioxide and carbonic acid in the blood. All right, so the respiration is very important because, again, by eliminating carbon dioxide, we can return that carbonic acid buffering system and our pH back to normal. Okay, so excessive carbonic acid accumulation, right, increases the rate and depth of respiration so that the carbonic acid is removed via carbon dioxide. Insufficient carbonic acid, right, is going to decrease the respiratory rate and depth, and then so it accumulates and allows for temporary accumulation of carbonic acid. Right, so increased ventilation or hyperventilation, right, is going to result in decreased carbon dioxide in the blood, right? So it basically reduces carbonic acid. Decreased ventilation, what we call hypoventilation. Remember, normal respiratory rate is somewhere between 12 and 18 respirations per minute. And so anything below 12 would be hypoventilation. So if you hypoventilate, then carbonic acid is allowed to accumulate, and this, remember, that becomes the reactant, and your carbonic acid and hydrogen ion become your products. Right? So your carbon dioxide level, right, indicates how effectively the respiratory system is in excreting our carbonic acid. Right, so they can't excrete, they can only excrete carbonic acid. They can't excrete other non-volatile acids like lactic acid and acetoacetic acid are non-volatile acids that cannot be removed in the same way that carbonic acid is. So if you increase your pH due to producing too much lactic acid, like if you overdid it at the gym, right, then the only way for us to really regulate our pH is going to be by getting rid of carbon dioxide. All right, and so we could do that, and then eventually our body can take care of the actual non-volatile acids. All right, remember, it changes and shifts them, and then they can go back into the cell or go to the liver and be converted back to pyruvate, which is usually what lactic acid does. All right, so you compensate, right? Compensation is your ability, right, to respond to some sort of imbalance of any metabolic acid, right? Except carbonic acid. Right, so compensatory response, right, does not correct the pH disorder. It does, however, compensate for it by adjusting the pH back towards normal, right? Other blood chemistry values are made abnormal in the process. Like I said, lactic acid are still going to be high, and then other mechanisms are going to have to get rid of the lactic acid, but the pH of your blood will return to normal if, of course, homeostasis and your compensatory mechanisms are normal. So it doesn't necessarily correct the problem that's making the lactic acid. If that is a recurring problem, it's just going to correct the pH for now. If it continues to make lactic acid, then you're going to be unable, perhaps, to compensate, and then you will have disease, which then would be listed as more of a respiratory acidosis or metabolic acidosis. All right. So a deficit of any acid except carbonic acid is hypoventilation. Excess of any acid except carbonic acid is going to result in a hyperventilation, right? So hypoventilation, deficit of any acid, and then excess of any acid is going to result in hyperventilation. So I don't know about you, but when I go to the gym and I feel the burn when I'm on the treadmill, okay, I breathe more. I don't know if you breathe less, because if you breathe less, then you clearly are not compensating very well, okay? So whenever you make more lactic acid, your respirations are going to increase in response, right? So for an imbalance, right, of a metabolic acid such as lactic acid, it begins in minutes, right? And then it requires at least several hours for full effectiveness, right? So what you're doing in the meanwhile is lactic acid was produced. Lactic acid eventually can go back to pyruvic acid. Remember, that was all glycolysis. I know, something else you have to go back and review. So glycolysis is going to take glucose and it's going to break it down to 2,3 carbon compounds called pyruvic acid. But in order for you to go into the Krebs cycle, you need oxygen. And sometimes when you're running really fast on the treadmill, you just don't have enough oxygen, okay? Because that's why we push ourselves, because we want to get better. And so to build up your cardiovascular system, you're going to have to undergo a little bit of stress. And that stress that you're doing is by increasing lactic acid, because eventually your body's going to compensate and it's going to make more oxygen containing molecules like myoglobin or hemoglobin, right? And so when you do that, then you're going to not get as tired as easily, right? So, but when you do make lactic acid, you need to go back to the liver, right? And utilizing oxygen, again, you're going to have to convert the lactic acid back to pyruvic acid, so then it can be incorporated back into the Krebs cycle when the oxygen is available. All right, so you can see here the respiratory responses, right? So the increase partial pressure of carbon dioxide, right, is decreased pH, right? And that's respiratory response is hyperventilation, right? And that corrects the imbalance. A decreased partial pressure of carbon dioxide, increased pH, you hypoventilate, and you are going to correct the imbalance. Decreased pH from excess metabolic acids like lactic acid, right? You are going to hyperventilate, and so now you're compensating. You're not correcting the imbalance, you're compensating for the imbalance. And then increased pH from a deficit of metabolic acids, right, which can happen, for example, when you throw up too much. So people who are bulimic, right, are going to excrete a lot of acid. And so they are going to go, you might see them be in hypoventilation. So that compensates for their imbalance. All right, so the third defense against acid-base disorders is renal, right? So they can excrete any acid from the body except carbonic acid, right? That's solely excreted by the lungs in the form of carbon dioxide. Excrete metabolic acids produced continuously during normal metabolism, like lactic acid. All right, so you can see here, right, some phosphates, right, the bicarbonate, right? And so this is a normal renal physiology, right? This is your nephron. This is your glomerulus, Bowman's capsule around your glomerulus, your proximal convoluted tubule, right? This is going to be your loop of Henle, your distal convoluted tubule. That's right there. You see the distal convoluted tubule going right past your glomerulus. That's where tubular glomerular feedback occurs, right? And then it goes all the way over here to your collecting duct, okay? And the collecting duct eventually is going to go to the renal pelvis where we make urine. Okay, so that's, here's a more simplified version of your nephron, right? And so the proximal convoluted tubule is where we're going to be doing most of our reabsorption. All right, so the ability to correct an excess or deficit of a metabolic acid depends on a normal renal system, right? So increased excretion of hydrogen, right? If metabolic acids begin to accumulate in the blood. Slows excretion of hydrogen if metabolic acid is deficient in the blood, right? So for example, increased excretion of hydrogen, right, can also increase the production of ammonia, right? And so hydrogen combines with ammonia and is excreted in the urine. The slow excretion of hydrogen, right, decreased production of ammonia, less, right, we excrete less hydrogen ions, so we reabsorb the hydrogen back into the blood, and we excrete bicarbonate instead. Right, so bicarbonate in the plasma reflects the effectiveness of our renal regulation of metabolic acids. So bicarbonate in the plasma is a very important measure, right? So it reflects the relative amount of metabolic acid in the blood. So decreased bicarbonate indicates a relative excess of metabolic acids. Does that make sense? Because remember, we're compensating. So you have a hydrogen ion that has to bind to bicarbonate to make carbonic acid. So if you have an extra production of metabolic acids, you want to adjust your pH by hiding away that hydrogen ion. And the way you could do that is by making carbonic acid, right? So if your metabolic acids are accumulating, right, you're going to buffer it by taking the hydrogen ion concentration that's made by these metabolic acids and buffering it with bicarbonate. So the bicarbonate is going to drop below normal. If you increase, right, your bicarbonate, right, that indicates a relative deficit of metabolic acids, because that means that we are taking carbonic acid and we're making bicarbonate and hydrogen ion, right? So there's a relative excess of the base. Right, so compensation, right? So renal response for carbonic acid imbalances. So our compensatory response for high carbonic acid levels, we increase the excretion of metabolic acids and hydrogen ion. For low carbonic acid levels, we decrease the excretion of metabolic acids and hydrogen ion concentration, and we excrete bicarbonate, right? So this requires, again, time. So if you have time, then you can compensate with your renal system. But this is not going to happen right away. The only one that can do things right away is going to be your respiratory system. And that's not going to be through a wide range of pH changes. All right, so renal responses to some changes in metabolic and carbonic acids. So nice little review on this chart table 25.3. So make sure you go through that. All right, so what are our 4 primary disorders? Okay, so our 4 primary disorders are metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. And I think you can try to appreciate what this means by looking at your carbonic acid buffering system, okay, before you try to tackle these disorders. Just look at the equation and see what we might be dealing with here. All right, so question 1. A patient has a deficit of carbonic acid. How will the patient's body compensate? Okay. A, the kidneys will decrease the excretion of metabolic acids and hydrogen. Let us think. The bicarbonate buffer system will take up the excess acid. Okay, so a patient has a deficit of carbonic acid. Is the bicarbonate buffering system taking up excess acid? If it is, then it would have a higher level of carbonic acid. Think about that. Look at your equation again and see how we make carbonic acid. Okay. The pH would decrease to less than 7.35. If a patient has a deficit of carbonic acid, pH will not be 7.35 or lower. Okay? because in order for that to occur, you would have to have significant amount of hydrogen ions. Okay? And we're not going to compensate by making more hydrogen ions. So it would say it would decrease to less. We're not going to take the little carbonic acid we have and break it apart to, again, look at your equation, hydrogen ion and bicarbonate. The lungs would increase the depth and rate of respirations. If we hyperventilate, what do we need in order to exhale in a hyperventilation? We require carbon dioxide. So when we hyperventilate, we decrease the amount of carbon dioxide. So in order for us to use carbon dioxide, we have to make carbon dioxide. And the only place to make carbon dioxide is by taking from carbonic acid. So if your patient already has a deficit, the lungs would not increase the depth and rate of respirations. It would actually do quite the opposite. So the answer is A. The kidneys will decrease the excretion of metabolic acids and hydrogen. All right, so acidosis is a presence of a condition that tends to decrease pH of the blood, making it more acidic. Alkalosis is the presence of a factor that increases pH of blood above normal, making it more alkaline, right? So, metabolic acidosis, relative excess of any acid except carbonic acid, right? So it may be caused by increase in the acid or the excess removal or decrease in the base, right? So combination of increased acid and decrease in base as well, right? So you see a decrease of the normal 20:1 ratio of bicarbonate, right? Which is the base, right? Bicarbonate to carbonic acid. So you'll see a decrease in that 20:1 ratio. Right? So where does these acids come from, right? In decreases of normal ratio between bicarbonate to carbonic acid because bicarbonate ions are used up in buffering excess acid. So an example of metabolic acidosis: starvation, ketoacidosis. Okay, so caloric and glucose intake is insufficient, right? So a person, because they don't have enough calories and or glucose, right, they are going to use fat stores for energy, right? Fat is going to result in making keto acids. Yes? That's why some people want to go into ketosis, okay? And this causes a metabolic acidosis. So ketoacidosis is something that is seen very commonly in people in diabetes, okay? So in starvation, and you might also see it in alcoholism, right? Severe hyperthyroidism, right? When you're burning through so much glucose, right? In burns, circulatory shock, tissue, anoxia, oliguric renal failure, and intake of acids or acid precursors like salicylates, methanol, or ethylene glycol. Okay, so these are basically things that are you need to call poison control for, right? Excess removal or decrease in base, right? So anything that causes a removal or the decrease in bicarbonate, like diarrhea. Okay, so diarrhea is going to lose intestinal fluid, right? It's very rich in bicarbonates, and that originated all the way back in the pancreas, and so you're going to have a metabolic acidosis. Also a gastrointestinal fistula that drains intestinal or pancreatic secretions. Remember, a fistula is an abnormal connection. So there's an abnormal connection that's rerouting things, right? Or intestinal decompression, or renal tubular acidosis as well. What are the clinical manifestations? Headache, abdominal pain, confusion, lethargy, stupor, coma, right? Those are some of the clinical manifestations, rather not specific, right? Non-specific, because that pretty much could be a whole lot of people. Now, Ketoacidosis, on the other hand, has a very distinct smell, right? So when you have a patient who is diabetic and they are not obviously taking their insulin, they're going to be in ketoacidosis and you will be able to smell it from a mile away. All right, so severe metabolic acidosis is also going to be seeing tachycardia, ventricular dysrhythmias, right? Decreased cardiac contractility, and then death is from brainstem dysfunction if the pH falls below 6.9. You will see an uncompensated ABG, arterial blood gas, where the pH is below normal. You might see a normal carbon dioxide partial pressure and a below normal bicarbonate concentration. Right? Compensatory response is hyperventilation. Very typical compensatory response. So low blood pH stimulates your peripheral chemoreceptors to increase your ventilation rate, right? And depth of respiration, right? So we are now going to increase the excretion of carbonic acid via carbon dioxide, right? So it does not remove the metabolic acids from the body. It just compensates, right? So, it does change the ratio of bicarbonate ions to carbonic acid, results in a compensatory increase in pH, which is what we need in the meanwhile to stay alive, right? If compensated metabolic acidosis shows decreased bicarbonate concentration, a decreased partial pressure of carbon dioxide, because that's compensating, right? Decrease or somewhat lower, even normal pH, depending on the degree of compensation. So which of the following would be associated with metabolic acidosis, right? So if you read them, central nervous system depression, increased serum bicarbonate level, prolonged vomiting or gastric suctioning, pH greater than 7.4, B, C, and D are negative, so the A is the correct answer, central nervous system depression. All right, respiratory acidosis. So any condition that causes an excess of carbonic acid, right? So you're caused by an impaired removal of carbonic acid by the lungs, so in impaired gas exchange, right? So in other words, we can't get rid of the carbon dioxide. So we can't get rid of, get rid of the extra carbonic acid to either compensate or regulate. So inadequate neuromuscular function in the lungs, right? And impairment of respiratory control in the brainstem. Right, so decrease the normal 20:1 ratio of bicarbonate ion to carbonic acid. All right, so impaired gas exchange is going to be seen in people with chronic obstructive pulmonary disease, right? Pneumonia, severe asthma, pulmonary edema, and acute or adult respiratory distress syndrome. Some people will call it acute, some people will call it adult. Right, so inadequate neuromuscular function might be seen in Guillain-Barré. Remember, Guillain-Barré is that ascending type of paralysis, usually due to antibodies and inadequate antibodies being created, right? It's an autoimmune disorder. Chest injury or surgery, right? Especially if pain limits breathing. Hypokalemic respiratory muscle weakness. Severe kyphoscoliosis, so that you have an inadequate ability to expand the lung, respiratory muscle fatigue, and impaired respiratory control with opioids or barbiturates that decrease the respiratory depressants. Right, so some clinical manifestations again: headache, tachycardia, cardiac dysrhythmia, neurological abnormalities, including blurred vision, tremors, vertigo, disorientation, lethargy, somnolence. In severe respiratory acidosis, you'll see peripheral vasodilation with hypotension. Right, so our uncompensated ABGs look like an elevated partial pressure of carbon dioxide. Obviously, your pH is below normal, but bicarbonate is normal. All right, so compensatory response: increased renal excretion of the metabolic acid, right? Since the kidneys cannot excrete carbonic acid, this is only in the respiratory, remember, as carbon dioxide. So they excrete hydrogen ion concentration and retain bicarbonate. So it results in a increase of bicarbonate ion, and that helps move the pH toward normal. But again, renal response needs several days in order to be effective. Right? So in compensated arterial blood gases, we'll see respiratory acidosis compensated by an increased, partial pressure of carbon dioxide, and then increased bicarbonate concentration, and decrease or even normal pH depending on the level of compensation. Right? A blood gas report shows the following: pH of 7.30, a partial pressure of carbon dioxide of 51 millimeters of mercury, which is elevated, and a bicarbonate of 23 milliequivalents per liter, which is normal. So the following conditions could produce these results. And why is it highlighted already to give you the right answer? Dun, dun, dun. So pulmonary edema is the correct answer. All right, so metabolic alkalosis, any condition that tends to cause a relative deficit of any acid except carbonic acid, right? So increase in the base, decrease in the acid, or a combination of both. So metabolic alkalosis, all right? So increase in the base, right? So intake of bicarbonate or bicarbonate precursors such as acetate, citrate, or lactate, all right? So massive transfusion with citrated blood, mild or moderate extracellular fluid volume deficit can also cause metabolic alkalosis, right? A decrease in acid, right? So emesis, gastric suctioning, mild or moderate extracellular fluid volume deficit, hyperaldosteronism, or hypokalemia can all decrease acid. So what are you going to see in people with metabolic alkalosis? Postural hypotension. Hypokalemia may also exist, causing muscle weakness as the potassium shifts into the cells. Remember, causes a hyperpolarization. You have tingly fingers and toes. You might see signs of tetany, which is a spastic type of paralysis, and then may progress to seizures, and then ionized hypocalcemia, right? So calcium binds to albumin, contributing to the excitability, right? So some of the clinical manifestations, right, include increased excitability of nerve membranes. So you might see belligerence as a clinical manifestation. Severe metabolic alkalosis, right, can cause central nervous system depression, right, and confusion, lethargy, and coma, and death usually occurs if the pH rises to 7.8. So in an uncompensated metabolic alkalosis, you will see bicarbonate concentration that is elevated, a partial pressure of carbon dioxide that is normal, and a pH above normal. So make sure you write those things down and keep those straight. Right, so compensatory response is hypoventilation. Remember, if you're looking at your equation, right, you want to go to the right to make more hydrogen ions. So you're going to breathe less so we can get rid of less carbon dioxide. Right, so need for oxygen drives ventilation, right, and prevents complete compensation. So obviously the compensation is not complete. Right, in a compensated arterial blood gas, you might see, in a compensated metabolic acidosis, our ABGs show increased bicarbonate concentration, increased partial pressure of carbon dioxide, and slightly increased pH. Right? So respiratory alkalosis, right? Any condition that tends to cause a carbonic acid deficit, usually hyperventilation. I always like to think of respiratory alkalosis as that person who is hyperventilating because they are arachnophobic, right? They have a fear of spiders and they see a spider and they start hyperventilating. And then basically they're going to pass out when they are hyperventilating. When they stop hyperventilating, you allow your body to return things to normal, right? So hyperventilation, right, is going to result in a hypoxemia. You might see acute pain. which increases your anxiety and psychological distress, right? You might see prolonged sobbing. You might, hyperventilation might be seen in prolonged sobbing or alcohol withdrawal, and stimulation of the brainstem, right, in a salicylate overdose, meningitis, head injury, or in gram-negative sepsis, right? So all those things can cause respiratory alkalosis and hyperventilation, right? And then you might see that numbness and tingling of the paresthesias, right, because of the increased neuromuscular excitability, carpal and or pedal spasm, right, decreased ionized calcium, which contributes to excitability, right? So central and peripheral membrane excitability. So the increased pH of the cerebrospinal and cerebral interstitial fluids alters brain function, brain cell function, can lead to a confusion or excitation, and you can have a cerebral vasoconstriction. So the uncompensated, right, the partial pressure of carbon dioxide is going to be abnormally low, right, because you're hyperventilating. pH is abnormally high, and bicarbonate is normal. All right, so your decreased renal excretion of metabolic acids, right? So you retain a lot of your hydrogen ions in the kidneys. Again, remember, this takes time. And kidneys excrete bicarbonate, right? So that we can, if we retain this, we need to excrete excess bicarbonate, right? So it returns the ratio of bicarbonate ions to carbonic acid towards normal, moving the pH towards normal. This takes several days, and because many causes are short-lived, may not fully be compensated. So in compensated respiratory alkalosis, you'll see a decreased partial pressure of carbon dioxide, decreased bicarbonate concentration, and somewhat high pH. All right, so mixed acid-base imbalances, right, where you basically have two primary imbalances occurring simultaneously. Second example is a patient with a bacterial pneumonia, right, and related respiratory acidosis, also develops severe diarrhea, like they might have if they have C. diff, right, Clostridium difficile, and then concurrent metabolic acidosis, right? So usually has a very low pH, and that could be fatal very, very quickly, right? So two types of primary acidosis or alkalosis may impair the effectiveness of our usual compensatory mechanisms, right? So pH will reflect the primary mechanism, either alkalosis or acidosis. And you might also see it occur with nearly normal pH if you have opposing. Primary acidosis and primary alkalosis are involved, like in a head injury with respiratory alkalosis, along with metabolic acidosis from a kidney injury. Right, so some neonatal and infant variations, right, since neonates often have a mild metabolic acidosis, right? Infants younger than 1 month are at risk for metabolic acidosis when they have a condition that results in any acid accumulation, because they have a reduced ability to excrete large acid loads. Their kidneys are less able to reabsorb bicarbonate. They produce a lot less produce less ammonia, and their urinary buffers are limited in quantity. Right, in adolescents, right, teens with eating disorders may develop metabolic alkalosis from repeated emesis, right, and hypokalemia, and or metabolic acidosis from starvation and or laxative-induced chronic diarrhea. And then geriatric variations, right, so usually a delayed ability to correct for respiratory acidosis because of their chemoreceptors being a little decreased due to age, so they don't respond as quickly to decreases or increases, in carbon dioxide, partial pressure of carbon dioxide, right? Increased risk of respiratory acidosis, right? For example, barbiturates have a very high drug half-life, a very long drug half-life. And then there's a risk, right, for metabolic acidosis if their kidneys are less able to excrete large acid loads. You might also see chronic laxative overuse that results in chronic diarrhea. Right, so that was chapter 25. And so I'll come back and see you for chapter 27. Right, so the case study, you'll work on it in class.